Thanks, Venu, and thanks, Kurt, for inviting me. This is a special opportunity because we never get to interact with our referring doctors. And because of this special opportunity, Kurt just told me I can keep you here till 6, I heard. So just talking about this, so just get ready. To keep this a little bit light, I just kept it more on the side of clinical cases that we'll discuss together, and we'll see what we can do with these patients. These are all real cases that I have seen over the past couple of years in my clinic. This is a 38-year-old female with mild obesity, and this is typical what you guys see every single day. She's planning an exercise program to lose weight. She has no other known risk factors for CAD. And what would you recommend if you're in your practice? Just a show of hands. Would you recommend an exercise stress echo? Anybody here? Wow, nobody likes stress echo. Exercise SPECT. Millen was just telling you how wonderful nuclear imaging is and all stuff. No? What about an exercise treadmill test? Nobody would send her for a stress test, even treadmill, put her on a treadmill, see how far she can go? Just a show of hands, don't be shy. No? And what about proceeding to the test without, to the program without testing? Wow, nobody wants to reassure this lady that she can walk on a treadmill. So in the recommendations, the guidelines currently for recommendations, you all are familiar with them. So whoever got the answer right can leave and go home now and just, we're done. So there is no really indication for stressing these patients. Also, although we see these patients every single day in our stress lab. Patients like this, typical patients like this, sent to us, oh, this patient wants to have a stress test, she wants to make sure what's going on. And one of the most unfortunate things is if they don't end up getting a regular stress test, because there's really no danger from that. But if they get a nuclear stress test particularly, because this is actually in a 38-year-old female, most often will lead to a false positive test because of breast attenuation. If the person who's reading the test ends up reading it properly, this patient will get a humongous dose of radiation for no reason, okay? And the false positive test might lead to downstream more testing. So there is no indication for that. Now, as far as stress echo, I don't think there is a harm for that, except for the utilization of the procedure that you don't need. You don't have any murmur, you don't have anything else you're looking for. This is a person with normal EKG probably, so she doesn't need that. Okay, so the reason we do stress testing in general, and this is whether you're coming from a primary care perspective or cardiology perspective, is first to diagnose a problem, to predict a prognosis, and to see if we have a response to therapy. So let's say you have a patient, you want to make sure they have CAD or not. So what you can do with these patients is basically send them to a test where you can make the right diagnosis. And Milen's showed you many examples where CT is actually a very valuable example or test to rule out completely CAD, because you can do many other tests and you cannot show the patients the coronary arteries at normal and they keep on showing up to the ER. So that's a great test to actually diagnose CAD or rule it out completely. Prognostically, one of the best tools we have for prognosis on these patients is actually treadmill stress testing. There is nothing that can beat that in a regular patient. So if you have a choice to send a patient for a stress test, this should be your first test of choice, a treadmill stress test. Irrespective of other things, we'll talk about some specific cases where it cannot be done. And as far as response to therapy, sometimes you have patients, especially if they have established CAD, you try them on some anti-anginal medicine protocol or some ischemia medications, and you want to make sure the extent of ischemia is smaller, or you want to make sure they're doing much better with that. You can do that. That's not used as much right now in the era of stenting and aggressive revascularization, but we still do it. So you can use it in patients where you're suspecting CAD. You can use it in patients where you have known CAD, but you're following these patients seriously to see if there's any change in their disease status. You can use it prior to non-cardiac surgery, stress testing, and that has to be, I think, the guidelines are moving more and more towards not using any stress testing prior to non-cardiac surgery because it confuses the whole field and muddies the water. And you can use it before and after cardiac revascularization. I'll give you some examples of when you do these tests. Now, there are some specific populations that it's very hard to risk stratify these patients without the help of some other imaging modality, namely women and diabetics. And we'll talk about that later in the talk. Now, you can have acute chest pain syndrome. In these patients, if they're clinically stable, they're ruled out, they have no EKG changes, it's appropriate to test these patients. Or you can use it sometimes in patients who have had a heart attack, and now you want to figure out, do they have any residual ischemia after the heart attack? Do they have any residual ischemia after complete or incomplete revascularization? Or you want to figure out what's their functional class before you start them on a rehab program. So that's also acceptable. Now, as far as going back to EKG stress testing, this has started long time ago, actually. They used to do just a series of steps, and patients used to walk up the steps and coming down and back and forth, and that was the stress test. They used to hook them up to an EKG, and they used to do that. This has evolved a little bit since then, and now we have basically a regular treadmill that's hooked up to an EKG machine, and that's how we do it. Over time, at least from our perspective in cardiology, and for many reasons, including financial, probably predominantly financial, we end up combining most of these tests with an imaging modality. So this was basically the growth of stress echo, stress nuclear, stress SPECT, stress MRI, and so on and so forth. The data for that was very solid back in the 70s and 80s when revascularization was not the standard of care and medical therapy was mediocre. The data for doing this kind of approach or combining or using all these aggressive imaging testing is probably less solid now in the era of aggressive revascularization and optimal medical therapy. So these are the things that I want to see if you have some understanding of. If you have a patient going for a normal treadmill stress test, what would you expect for the diastolic pressure? Would you expect it to increase by 20 to 40 millimeters, drop by 20 to 40 millimeters, this is diastolic blood pressure, to remain unchanged, or to increase proportionally to the systolic blood pressure? So let's start with A. Who would choose A? We have one taker there. That's strong. In Ohio, actually, it will probably increase to 20 to 40, but I'll tell you later because they're all deconditioned. We'll take the next one. Who would say dropped into diastolic blood pressure, 20 to 40? Who would say the blood pressure will drop, the diastolic blood pressure? No one. Who would say it will stay unchanged? We have a few takers. And who would say it would increase proportionally to the systolic blood pressure? Okay. So that's a good question. So let's see what happens physiologically in a regular patient after stress testing. You will have an increase in heart rate. If you don't have that, you have chronotropic incompetence. You have increase in stroke volume in proportion to demand. You have increase in cardiac output as a combination of increase in stroke volume and the heart rate. You have vagal withdrawal to allow the increase in the heart rate. And you have sympathetic stimulation. All of these will achieve the same thing. What you will have early is also, this is what differentiates actually a trained person from a non-trained person. A trained person will sustain an increase in stroke volume or cardiac output due to increase in stroke volume very early and continuous throughout exercise. And that's why their heart rate doesn't rise. Whereas a non-trained person will actually end up having an increase in cardiac output depending only on the heart rate. So they will have a very fast rise in the heart rate early in exercise, and therefore they tire out right away and they cannot continue. So what happens else with the blood pressure? You will have a systolic blood pressure, a mean arterial pressure will go up. The diastolic blood pressure usually remains unchanged. It should not go up. If it goes up, that's basically a sign of deconditioning. That's a sign of diastolic increase in blood pressure with exercise, which is actually abnormal. Now you will have also the mean increase in heart rate. What happens to the maximum predicted heart rate? That will drop with age. And we look at that, and we look at those targets for patients where they should go as far as the heart rate. Now we're finding more and more, actually, I'm doing a project with one of the fellows, we're finding more and more right now that our population that's sent for just plain EKG stress testing is reaching their maximum predicted heart rate much earlier than they used to 20 years ago or 15 years ago. If you compare the same population now, the same age group, now and 15, 20 years ago, they're getting to this maximum heart rate much earlier. And the reason for that is because of the sedentary lifestyle. These people will be becoming more and more sedentary as we industrialize. Now, the treadmill protocols we use are standard. We have multiple different types of treadmill protocols, but again, if you have a patient, you're going to send them for prognostic or diagnostic data, please order a stress test and an EKG stress test if they can walk. And don't promise them they're going to go just lay in the spa at the Cleveland Clinic and have a pharmacological stress test when they're 38 years old. We see that ordered all the time, and we just don't know. It's very hard to switch it, and it messes up the protocol. So if you can, just make sure you focus on the treadmill side of the stress test. That's the most important part of any stress test. So usually we do a Bruce protocol on most young people, and we do a modified Bruce protocol as they get older, and we do other types of protocols as they get into the high age group. Now, as far as contraindication for stress testing is extremely safe. We rarely ever have an event or a problem with a stress test. The death rate is it's calculated about 1 in 2,500, but it's probably lower than that. And as far as absolute contraindication for stress tests, we don't want to stress somebody who's having an acute MI actively. We don't want to stress somebody who's having unstable angina presenting with chest pain and EKG changes or positive enzymes. We don't want to stress somebody who's having a dangerous arrhythmia. We don't want to get somebody in VTAC or something like that and stress them. Now, as far as symptomatic severe AS, usually we don't like to stress those patients. Under certain circumstances, we do it in cardiology to figure out if actually they are symptomatic to provoke some symptoms. We do it for some other reasons, for risk stratification, but in general, they shouldn't be stressed. If they have heart failure symptoms or heart failure on physical exam, they should not be stress tested. And other things like aortic dissection, common sense things, pulmonary embolism, and so on and so forth. Now, the relative contraindications, you leave them to us, we'll be fine to deal with those, is if you have some mild valvular disease or moderate valvular disease, if you have electrolyte abnormalities. We usually check on these things before the patient got on a treadmill, and we'll worry about that. Now, we often end up stopping the treadmill when these patients, for multiple reasons. One of them is if they develop crushing chest pain, or they pass out, or if they drop their blood pressure. We've had many events where the patients actually have never seen a treadmill, have never walked, so they just walk for a couple of seconds and then they just fall off, and it can be scary. But in general, if I want to stop here just for one thing, which is the syncope issue. If you think syncope is related to exercise, please don't order a pharmacological stress test. We have patients, I think 5 or 6 patients every single day sent to our nuclear stress test lab because they were dizzy or have almost symptoms of syncope around the time they were walking or exercising. And the next thing is we're doing a pharmacological stress test on them. We're not exercising. We're not reproducing the scenario under which the syncope or the dizziness happened. So it is a daily thing, and I keep on calling back the physician and say, do you mind if we're switching it? It tends to be a little bit on the nonsensical part because we're doing something that has no contribution to the patient's symptoms. Now, I'm going to skip over these things so I can get you home. We look at a few things when we do a stress test. We're not looking only at the EKG. We look at the hemodynamic response. That's why I mentioned the blood pressure earlier in my question. We look at ST changes. We look at the heart rate response. But all these things have compromises. So if you look at the ST depression, it's not specific for coronary artery disease. So if you look at, let's say, patients who develop ST depressions, and that's one of the weaknesses of exercise treadmill testing, is you have patients who have severe hypertension. These patients have non-specific ST changes with exercise. They don't mean it doesn't mean they have CAD. It means they have subendocardial ischemia. Patients with aortic stenosis, they can have EKG changes without CAD. Patients with cardiomyopathy, patients with anemia, patients with electrolyte changes, patients on DIG, patients with WPW, all these patients can have EKG changes. Therefore, it renders the test non-diagnostic. But it doesn't mean we should not exercise those patients because we get a lot of information from the non-EKG part. I mean functional capacity, response to blood pressure, heart rate response, all these things to the patients. Because all of you have seen patients who will tell you, oh, I can do everything. I can walk, I can exercise, I can do all the stuff. And they remember themselves, from the days of high school back in the Eisenhower era. And then you get them back and you put them on the treadmill, and after 1 or 2 minutes on the treadmill, they cannot walk. They get very short of breath and they just fall apart. And you just prove it to the patient. You can work, you can actually use this tool to tell the patients how deconditioned they are and how far down that deconditioning path they've traveled. Now, every time we talk about a stress test or we talk about any test in medicine, we have to talk about which population we're testing, because the pre-test likelihood of disease predicts the post-test likelihood of this disease being correct or incorrect. And then we talk about sensitivity and specificity. So you cannot talk about sensitivity and specificity independent of the population tested. So if you take a bunch of females between the age of 20 and 40 and send them for nuclear stress testing, the specificity of any of these findings, meaning if I call the test positive and I send it back to you, the likelihood of that test being truly positive is extremely low. So the false positive become very high. Therefore, the specificity drops and the specificity will be probably under 50%. Okay? So this is not the population you want to test using this test. On the contrary, if I take a bunch of 67-year-old males who have a couple of risk factors for CAD and send them for a nuclear stress and then find they have a positive test, the specificity will be in the high 80s to 90%. So the specificity is not only test dependent, it's population dependent. Okay? So when we talk about EKG stress testing, we're talking about, let's get to that. The sensitivity being, that's why we give a range between 61 and 73%, and the specificity is 59 to 81%. And I keep on saying this, the true value of is for a negative treadmill test is the event rate. When we have a patient, let's say myself or anybody else, and they go on a treadmill and they exercise for 10 minutes, we did not rule out CAD. And that's the message we don't want to give the patient. We told that patient you have excellent prognosis, which is different than ruling out CAD. They might have CAD. They might, Melinda Desai might do a CT on them and find they have plaque everywhere. But it doesn't mean that when we tell them that stress test was normal, that they have no coronary artery disease. So we want to make sure that we clarify that to the patient and to you guys, because you guys interact with them more than us, to tell them the stress test is normal. Your likelihood of having an event in the future is under 1% per year. But we did not look at the coronary arteries. We told you have no CAD. So that we shouldn't tell the patients that. Even if you do nuclear stress testing or stress echo, the same applies. We never tell the patient you don't have CAD. We tell them your prognosis is good. So here's a meta-analysis of a large study of 24,000 patients looking at sensitivity and specificity of EKG stress testing. It's limited. And this is in all comers. We're not saying this is to diagnose CAD. This is not to predict prognosis. This is on the diagnostic side. So if you're trying to diagnose CAD, yes or no CAD, this is not a very good test to do that. If you're trying to predict prognosis, this is a good test. Now, this is a good test if for a patient who tells you, if I have angina every time or chest pain, every time I walk, and you walk on a treadmill and they don't have chest pain, they don't have EKG changes, it's unlikely that chest pain was cardiac in etiology, right? Now, how does EKG stress testing compare to other things? Because people like myself on the imaging side will always tell you, oh, imaging is the best thing you can do. Probably that's not true. So if you take one vessel CAD, yellow is being stress EKG, and then we go to red being nuclear, because I want to discourage you from ordering these tests unless you have an indication. You will end up, Kurt, am I going to lose my job in nuclear after all this? I'll be fine. So if you can't look at this population, so you take one vessel CAD, actually nuclear stressing is excellent because it's looking actually specifically at different walls, and it can differentiate between circumflex versus anterior wall versus meaning LAD versus RCA. It's a very good test for that. EKG stress testing is not very good at that because it's not very sensitive to pick up small areas of ischemia. But as you travel up in the number of vessels and you go to 3 vessel CAD, you can see these tests actually perform equally. So if you're suspecting, I'm sending this patient for a nuclear stress test because he might have 3 vessel CAD, and I want the best test for them. Actually, the best test can be any test. It doesn't have to be a nuclear stress test. It doesn't have to be a stress echo unless you're looking for something different. So this is, in general, the way you have to think about these tests. They're great tests if you know which scenario you're calling for. What about specificity? Actually, looking at stress EKG, it has intermediate specificity compared to nuclear and echo. Again, we talk about nuclear as a very non-specific test in a setting where you're sending the wrong patients for that test. Because nuclear stress testing is plagued with artifacts. It's plagued with artifacts because you're trying to image something that's sitting next to the gut, right here, where if you have a lot of gut activity coming from the injection, you end up not seeing the inferior wall very well. If you have a patient who is young and healthy and thin, you get a lot of diaphragmatic attenuation in inferior wall. You cannot see it very well. If you have a lady, you get breast attenuation. If the patient, this test takes about 12 to 15 minutes on the camera for each stage, and the patients have to lay still for 12 to 15 minutes. Try to do it yourself. There's no way you can do it. They move, you get motion artifacts, therefore the specificity is lower. Then we get something called the Duke Treadmill Score. Everybody here has heard of the Duke Treadmill Score, right? This is, if you haven't heard of it, we'll talk about it anyway. So what about the Duke Treadmill Score? This is a treadmill score that was developed looking at to combine all these data we get from a stress test. So again, a question for you. This has been validated in young men. Anybody want to raise their hand on that? Any takers? We have a guy there. Good. Validated in women? Come on, you have to be equal opportunity. You're not going to raise your hand on that? No. It's not, according to him, it's not validated in women. Validated for diagnosis of ischemia? Anybody? No. And validated in the elderly. Has it been validated in the elderly population? Wow, nobody wants to pick a choice. Guys, they teach you in multiple choice questions. You have to pick one. At least you get 25 chance being right. 25% chance you're missing on it. Anyway. Yeah. It's not. It's not. It is not. So the Duke Treadmill Score, it combines prognostic markers like time, we'll talk about it in a second. It combines how far you go on the treadmill. It combines the ischemic issues related to EKG changes. So it's been validated in men and women equally. It's not been validated in the elderly because back then, the age for patients presenting with CAD actually has been shifting up. So if you go back to the 70s and 80s where most of this data came from, the age for CAD was in the early 50s. Now patients presenting with CAD are a bit older than that. They're in their 60s. So they didn't have a large population, large cohort to validate this population. Now what is incorporated in the Duke Treadmill Score? Which one is not part of the Duke Treadmill Score? Numbers of METs achieved. METs, everybody worries about how many METs the patients went. Is that in the Duke Treadmill Score? Yes. Development of angina, is that in the Duke Treadmill Score? Yes. ST depression, is that in the Duke Treadmill Score? What about time on the treadmill? Is that in the Duke Treadmill Score? No. Okay. So here's the Duke Treadmill Score. It tells you duration of exercise in minutes, which is excellent thing to know for the patient and for us. ST changes, which are a reflection of ischemia most of the time. And then whether they developed angina or not. So this has been validated quite well. So let's look at the Duke Treadmill Score in this instance. So if you have a patient who goes on a treadmill and they have a very normal Duke Treadmill Score, their event rate over the next 4 years, okay, is under 1%. You can't beat that. You cannot beat that with any medication, any further downstream testing. We don't have any invasive test that's as safe as that. Okay, so this is the data we want to get on, or these are the data, the information we want to get on our patients, is what's their prognosis, and balance that prognosis, great prognosis they have, to any other test we might subject them to. All right? So we might feel great about giving them all the advanced technology, but the advanced technology might not offer them the safety we have from this kind of test. Whereas a patient with very high Duke Treadmill Score, these patients have an event rate that's very high, and therefore you can justify going the invasive routes. The next case is a 43-year-old male patient, past medical history of smoking and hypertension. He's here for a checkup at his wife's request, typical. His BMI is 32. He has normal baseline EKG. He reports feeling well and doing all the things he wants to do without any difficulty. 43-year-old guy. His wife insists on he gets a stress test. You as a PMD ordered a stress echo. He achieved a 4.5 METs, no EKG changes, and his stress echo was normal. His wife was one of our administrators at the Heart and Vascular Institute at Cleveland Clinic. Asked if the test is normal, because she was told the test is completely normal by the PMD. Okay? So you told the patient, let's see, A, in the absence of EKG changes, symptoms and wall motion normality on the stress echo, the test is normal, and he has very good prognosis. Who would take that? We have one in the back. 2, 3, 4, wow. Okay, good. His pre-test likelihood of disease is low, and therefore the test would have not changed his post-test stratification. This guy is asymptomatic, he's 43 years old. All it is his wife is telling you that, she wants to know about him. She wants to buy life insurance. No? No takers for this one? Oh, we have few here, good. Clearly, a pharmacological stress test is needed given the poor exercise capacity. Who would take that? Who would take he's doomed? I'll take that one. Okay. So remember, this is a 43-year-old guy. If he can exercise only 4.5 meters, what's 4.5 meters? Basically climbing from the first floor to the second floor in his house. That's 4.5 meters. That's all he can do on a treadmill. This person has a very poor prognosis. This test is not normal. The imaging did not help us at all here. Actually, it confused the whole thing. The imaging reassured us, gave us a false reassurance, everything is fine, but not everything is fine. This guy has a problem. He has a very limited exercise capacity. So for every increase in 1 MET, you get 10 to 15% increase in survival. For every 1 MET, okay? So the only way you can increase METs, fortunately, is by losing weight and exercising. Easy thing to do, right? Now, the ballpark you guys want to look at, if you're in primary care, is the 7 METs. Patients who achieve less than 7 METs don't have a good prognosis. Patients who achieve more than 7 METs, it's very hard to justify other things for them because they have a very good prognosis from a prognostic standpoint, all right? So just keep that in mind. If you see on your EKG stress test under 7 METs, start worrying about the patient. Now, we're not talking about the 92-year-old. We're talking about the general population. Okay? So I'm going to skip just one more case and I will stop there. 73-year-old male patient, elevated cholesterol, typical patient you guys see, hypertensive as far as risk factors for CAD. He's asymptomatic, describes himself as very active. His life insurance carrier asked for an exercise test to assess his prognosis. Okay? His EKG shows normal sinus rhythm with left bundle branch block. So you inform him that's the insurance sent him for an exercise stress test. We can proceed with the test for the above indication. He's coming here for a stress test. He has a left bundle branch block and the EKG. Who will do a regular stress test on him? Just plain old stress test to satisfy the insurance company? No one. The ability of the test to predict prognosis is compromised by the presence of left bundle branch block. Who would pick that? Okay. Prognostic information can be only derived from a pharmacological stress test because he has left bundle branch block. Who would pick that? And this Millen would be very happy with that. The insurance carrier should have paid for a CT angio. Who would pick that? Why not? Here you go. So let's talk about this. Symptomatic patients or patients with CAD should undergo exercise imaging tests if they have pre-excitation, right? Ventricular paced rhythm, widespread ST changes, or left bundle branch block. Okay. Symptomatic patients or patients with CAD. Now, exercise testing can be used in the above patients for prognosis assessment. Nobody told us they want to diagnose CAD or not diagnose CAD. They want prognostic information on this patient. The prognostic information cannot be derived from a pharmacological stress test. You need the treadmill. So I wasted about half an hour of my life and your life telling you that you should send everybody for a treadmill exercise test to get the prognostic information. This test was ordered for prognosis. It was not ordered to diagnose CAD or ischemia. No one asked for that. So you could have sent the patient easily for a regular stress test and got the information. If he can exercise above 7 METs, then his prognosis is good and the insurance company will be happy. And that's what we did with this patient. All right? I'm going to stop here just to get you back to your families. Thank you so much.